I thank my friend for this type of introduction. And again, my name is Ayman. iPhone, iPad, Ayman, not Ayman. Just for a reminder. Amen. So that's why you call me like your wife. You know? Okay, that's good. It's my honor. All right, let me see what I have here. Okay. So I think I have maybe 25 minutes. And I have to say that I will have to stop after that because I'm losing my voice. So I'm not going even to, finish with Dr. Jalaf about the rest of the TDM and the best dose things. And he is the expert, so I'm not going to have anything in between. So I will just introduce the concept of the TDM for the individualized drug therapy. And I have to say that, it's my pleasure and honor to work together with Dr. Roger Jalaf. He's a great guy, an icon, TDM and pharmacometrics and pharmacokinetics, a clinician and specialist for years and years and years. And I really feel blessed and honored that I'm really attached to this big name, which is big. For me, it's a big thing. For me, I'm going just to make some sort of, laying the ground and introduce you to the concepts. And then Dr. Jalaf will begin to get you the real things about the best dose, about the metrics, and the whole heavy-duty stuff. So bear with me for the next 25 minutes, and I'll try to make it as simple as I can. Simply, as pharmacists or as clinicians, what our real goal, our goal at the end of the day is to give our patients the right drug, the right indication, for the right patient, at the right time, and the right dose. This is the ultimate goal of what we want to do day and night. Just to get these things right is our objective. And I think the right drug for the right indication, right patient, right time, this is normal practice. All of you guys, all of us are really used to have these things, and we are taking care of all of the things. This is part of our pharmaceutical care responsibilities. What I'm going to do today, which is my real interest and my passion, is to make sure that we give the patients the right dose, i.e. optimizing therapy. And when I say the right dose, I mean that the specific personalized dose for that patient, because one size does not fit all. And this is a problem for our clinical practice, that it's always one size fits all. You just give the dose and that's it. You don't know exactly what's this patient, age, physiology, what happened to the renal function, what's happening to the liver function, what's happening to the immune system, what's happening to the physiology, the blood pressure, the circulation, everything, drug interactions, other drugs there, food interaction. This is a very complicated process, and we cannot simplify it by just sampling, hey, give 500 milligram twice daily, or give 10 milligram BID, and that's it. This is a major problem in our clinical practice as clinical pharmacists. The pharmacotherapy is wishy-washy therapy. And the physicians, basically, they tend to have the overall guidelines just as they follow, and there is no real attention to the patient condition. And that's why we are trying to push the term for individualized medicine, which is very important, to make sure that we give that drug at that dose that's adequate for that patient, not for me, not for you, not for this person, because each one of us has different, reaction to the drug, different response, and at least for sure, well-documented different kinetics based on different factors. So we have to pay attention to therapy per patient, and this is very important. So the way we treat patients is simply to identify the objective, the goal, what I want to do. I want to decrease the blood pressure to that level, or I want to treat hypercholesteremia. I want to decrease cholesterol, to that level. I want to kill this, bacteria. I want to do, this is the objective. And then I choose the drug and the dosage regimen, which is very important. This is the most important component here. But do I stop here? No, I don't stop here. I have to monitor therapy, especially for toxic drugs or drugs with narrow therapeutic window. So I monitor the response and observe for any adverse effects or toxicity, and then come back and work within the kinetics and the dynamics and the kinetics, and maybe I can change my objective. I can tailor my therapy based on what I find. So that's why continuous monitoring of therapy is very important to make it a successful process. I can give you examples of different TDM, therapeutic monitoring, just simple things, just simply by clinical response. You just watch for furosemide, which is basic for, I'm going to give just an example, heart failure. So if you have increased urea and dehydration, decrease the dose. If you have edema, you just increase the dose and observe for toxic effect and toxicity or hypotension. So it's just simple monitoring for the clinical outcome, and you can change accordingly. This is still not really scientific, but this is the things that are happening all the time. This is by clinical response. The second approach is just simply to monitor through in vitro testing. So for example, in warfarin, you watch for the INR, and this is for thromboembolic disease. And if the INR are high, decrease the dose. If it's low, increase the dose, and try to watch for bleeding. This is very important, and so on. This is an example of in vitro testing. You just take some blood level and try to identify some markers for the therapy. And in this case, very obvious that the INR is the one here, and we go out with this thing. For the thyroxine, it's TSH. For statin, you just talk to ST. All the liver function things are important here. So this is simple, straightforward. But again, for some conditions, when you have drugs that are really toxic, and I call it, this is simply narrow therapeutic window. So you can have a window of therapy is just narrow, that below that is not going to be effective, above that is going to be toxic. So you are really working on a very risky situation here. You have to be careful. You can't be wishy-washy therapy here. You can't adjust the dose by saying, okay, increase the dose, decrease the dose, and that's it. You can't make some sort of estimate and assumption. You have to have numbers, you have to monitor, to have calculations, and you have to make sure that you are giving the drug within the therapeutic window. This is very important. Otherwise, the patient either will be subtherapeutic, it's not going to have an effect, or it's going to go to toxicity, and sometimes it's fetal toxicity. So it's very important to have close monitoring, and this is what we talked about, which is basically close monitoring of drug therapy. We just basically take drug levels quantitatively and try to correlate that with therapeutics and toxic effect. And this is very important, because if you miss something here, if you screw something here, you're going to kill the patient. This is very important, especially for drugs that are really toxic, with the therapy there, like, aminoglycosides, for example, like, phenytoin, like lithium, theophylline. If you don't adjust the dose within the therapeutic window, you are going to run into serious troubles with that patient and might be fatal at one stage. And that's why it's very important. It's very important to emphasize TDM, especially for all of these dangerous drugs. Now there is some new trends now to even to extend it more beyond that to maybe chemotherapeutic agents, because they are still very toxic, very dangerous drugs. But you have to monitor that to make sure that you really give them the right dose to this patient. And again, one dose does not fit everybody. One size does not fit everybody. You have to specify the dose for that patient. And that's what Dr. Jealous is going to talk about today, that the tools he is using to make sure that you give it to the right patient with this type of condition, with this type of physiology, with type of renal function, with this level of toxicity. You have to make sure that you tailor therapy to your patient need, patient by patient. You don't just assume that 10 milligram once daily it will be given to them, and that's it. No, you have to have close monitoring, you have to have levels, do the calculations, do the math, understand everything about the patient, understand everything about drug interaction and other medication and other therapy, and then begin to come up with the real dose for this patient. This is very important. And this is an example of some drugs that have low therapeutic index. I call it, a narrow therapeutic window, and these guys are having some sort of variable kinetics. When you have a drug that have saturable elimination, very dangerous. If there are also some sort of genetic factors like the poor metabolizers, and this is now when we have the pharmacogenomic science is starting to evolve right now, and if you have different drugs, multiple pharmacy, you have different drugs at the same time that are interacting that can increase or decrease the metabolism or elimination of the patient. Now we have serious condition of increased concentration to the toxic level or decrease it to less than therapeutic, the subtherapeutic. And this is when you have to dig in and have close monitoring. That's why we call it therapeutic drug monitoring. I'm not going to talk about that. This is a description. I'm going to give you just simple example here. I'm an antibiotics person. So I'm going to give you our story, the way we try to do it, in the antibiotics field. How would we develop some science to make sure that we identify different factors in antimicrobial therapy, and then how did we come up with some sort of models to make sure that we give the right dose to the right patient. Dr. Jelif will take over after that to give you the broader picture and give you more advanced and sophisticated tools, including the best dose, and hopefully you can talk also about the P metrics to give you the whole picture and the tool that will help you to understand that concept. But I will focus here on the antibiotics in my business, my little shop, what we do in the lab to try to identify these issues. So again, as I talked about it before, we try to make marriage between kinetics and dynamics. And again, we have all of this stuff that I talked about it, that you make sure that you get some identified parameters to identify the outcome. So now we know that we have to give this dose to treat this type of resistance, and now we are quite sure that we are giving the right dose for that patient who is infected with that organism, with that level of resistance. This is more specific type of therapy. And now we end up with new theories. In fact, there is new classification of antimicrobials right now. And where you have some parameters that can indicate efficacy. For example, the parameter that we reach here is that the concentration, which is the peak above the MIC, this is one very important parameter. The time the drug spends above the MIC, another very important parameter. Area under the curve above the MIC, another very important parameter. And again, as I said all the time, when you talk about AUC or concentration, you talk about the free drug. So you have to calculate for the protein binding here. Then there are some other sub-parameters like the post-antibiotic effect, persistence effect, the sub-MIC, post-exposure, all of these things, or even the immune system, post-antibiotic affected by the leukocytes. These are factors that you have to consider. But for sure, these are the PK/PD principles or parameters that we have to focus to make sure that we can tailor the therapy or the dose of the antibiotic to that patient with that kinetics, with that infection, with that organism, with that resistance level. This is very specific approach to make sure that we can have good effect. So now, at the end of the day, we ended up with 3 categories of antibiotics. In fact, I'm going to divide them just to summarize to 2 only because the third in between made lots of confusion. So we just, let's say 2 now, right now. We talk about antibiotics that are time-dependent killers. There is no effect of the concentration or the amount of the drug you give. The example here are the beta-lactams, like cephalosporins, like the penicillins, meropenem, clindamycin, oxazolidines, some macrolides, but this is again now changed to the other side, fluocytosine. But what's your goal here? Your goal is to increase or optimize the duration of exposure. You don't have to worry about the amount of the drug, i.e., let me say a patient was given amoxicillin 500 milligram Q12 hours, every 12 hours. And it was found not to be effective. The patient is not really recovering. And you want to optimize the dose. In this case, because this is a beta-lactam, what you do? You increase the dose. Let's say, let me tell them, make it 750 to 12 hours, or give the patient 1,000 milligram to 12 hours. This might be a choice. No. Based on our rule here, this is a time-dependent killer, i.e., the only factor that will really judge the outcome is the duration it extends or extends above the MIC. I.e., you need to make sure that when you give the drug Q12, you need to make sure that you have a concentration above the MIC as long as you can. How can you do that? By increasing the frequency of therapy. So you decrease the time. So other than giving the amoxicillin Q12 hour, give it Q8 hours. Or give it the same dose. Or give it Q of every 6 hours. This way, you give one dose. Before it goes down below the MIC, you give the second dose. Before it goes down the MIC, you give the third dose. Then the fourth dose. So once you give it Q6 hours, you are sure that the beta-lactam is spending longer time above the MIC. You don't have to change the amount of the drug. And this is a very important factor because, hey, if you look at your practice site, you'll find that most of the clinicians and the clinical pharmacists, when you have amoxicillin every 12 hours, so it doesn't work perfect. Give them 1,000 to 12 hours. Increase the dose. Just give them more drug. And this is absolutely wrong. It is better to keep the same dose, but give it more frequent, Q6 hours or Q8 hours. This is the outcome of what we did. We proved that those drugs, like the beta-lactam, clindamycin, oxazolidones, macrolide, some of them, this is not all of them are time-dependent killers. It depends on the time they spend above the MIC. And your goal is to optimize the duration of exposure of the drug. All right. The other group, I removed the second one because it's basically between wish and gut. Now it's so proven that it's just only two. So the other group, we call them concentration dependent killers, i.e., simply their killing effect depends on the amount of the drug and the level or the Cmax or the concentration it achieves in the blood. The more you give, the better the effect. The higher the dose, the better the effect. Higher the concentration that you achieve, the better the effect. Examples, aminoglycosides, like gentamicin, amikacin, all of these guys. Tobramycin, all of these guys. Fluoroquinolones, right? Levofloxacin, Cepro, and Dati, all of the ones. Daptomycin, ketolides, and amphotericin. In this case, what's your goal? Is to optimize concentration and amount of the drug, i.e., you increase the amount of the drug, increase the dose as much as you can. Of course, you don't exceed to the toxic level, don't give mega dose, but you can increase the dose, double the dose, whatever. But you increase the amount of the drug. This will increase area under the curve, 1 point. When you increase the amount of the drug divided by the BD, it will be the Cmax. You increase the Cmax or the concentration of the drug that you achieve. So other than achieving 10 microgram per ml, you achieve 15 or 20 or whatever. The more you increase the concentration, the more you increase the amount, the better the efficacy and the effect and the outcomes. And this is for this type of the antibiotics. And we are always worried about the peak Cmax and also worried about the AUC compared to the MIC. This is very important. That's why, do you know about the single dose glycoside? It's based on the same theory. And it was, I think, introduced by David Nicola in Harvard Hospital, Korea at that time. that they thought about it and said, hey, we give gentamicin 80 milligram Q8 hours, and we try to follow the kinetics. But this aminoglycoside is a concentration dependent. So it's better to increase the dose. So what if we give it a mega dose, increasing but other than 80, we just make it, let's say, 450 once daily. So you reach a peak, high peak of the aminoglycoside. Once you reach high peak, you need what? More killing, quicker killing, better killing, faster killing. At the same time, when you leave it to go down to the trough, you go to the second dose, the second day, you are still having the effect of the drug, because this is a concentration killer, and it has also what we call it post-antibiotic effect. So there is no problem if you get it to lower than the trough, and you get it to the second dose, and so on. And it was proven that at least it is less, it's equal to the conventional dose, and at least it is not more toxic. So some theories, it's not proving it that it has less ototoxicity, and some theories that it has less toxicity on that. I'm not going to go about that. But at least you achieve the same effect. I'm arguing again that I know that it's more than the same effect. But at least think about this, other than giving Q8 hours. Nurses have to give 8 hours and 3 injections or 3 infusion every 8 hours. We just give 1 injection, 1 infusion every 24 hours. So at least from the economic point of view, we are achieving something. And from the clinical point of view, based on the theories here, it is more effective and less toxic. So this is why you have now this single dose aminoglycoside, once daily dose aminoglycoside. You have now extended infusion of meropenem, or even continuous infusion of meropenem. Essentially, meropenem is aminoactam. It is not concentration dependent. It is basically time dependent. So what had happened is that you want to keep the concentration above the MIC. So other than giving meropenem Q8 hours, give meropenem as a continuous infusion. So this way you have higher than MIC, keep the infusion for 24 hours. You are sure that it is above the MIC. So we use all of these principles to optimize therapy for the patients. All right, so how we achieved this type of model, I'm going to go over that quickly. We did some lab works, we did some animal works, and then our clinical simulation that I showed you, the Monte Carlo, all of the things here. For example, the lab work, this is a model it's in almost most of our PKPD guys like me and my friends, George Zanel, George Rosano. This is simple, one compartment model, and this is a central compartment where you have like the blood, and you have the bacteria growing here, and you have the blood. It's basically a broth like a blood, and there is a pump that can pump the blood into the central compartment, and then the pump that can get it out of the central compartment. This is typically a model for antimicrobial effect. When you have the antibiotic added here, and you take samples, you can now follow the growth and kill for the bacteria in the central compartment. And this is a picture of the model here. Another model here that I built, I called it shish kebab, because I like it. It's basically the same thing, but we have more advanced model here, because we have modeling a biofilm infection, not just simple infection in the blood. It's basically the chronic infection in prosthetic valve, for example, or in chronic infections, in the wound chronic infection, maybe in the bone infection. So we model that, and we have copies here, and we grow the biofilm bacteria here, and then we run the blood here, and these are the 2 pumps here from the main compartment to the central compartment, and then to the outlet compartment. And then we take samples over time and try to calculate the outcome of therapy when we add antimicrobial to the central compartment. So this is basically a modeling that shows us what happened in vitro when we have different doses and we have different bacteria. So we model what happens in the real life there. Another sophisticated model, which is a tissue culture, hollow fiber tissue culture bioreactor model. And here we have nanofibers here and very small pores in between where we can grow cells. And I use this hollow fiber, by the way, for cancer therapy. So because I grow cells here, I grow cancer cells. For example, we have experiments with growing glioma cells in a 3-dimension. And then again, we have pumping of the like the blood and then the outlet here. And here we can have the addition of the drug or the chemotherapeutic agent with a pump, so we can model the therapy of the drug, and then we can have samples and follow up the growth and kill of the cells at the same time. I use that model also to grow epithelial cells like kidney lining cells, lining epithelial cells for the kidney and even for the lung. And then I infected it with Pseudomonas aeruginosa, and then we began to give the drug and see what happens if we have chronic infection like cystic fibrosis in this model. So this is a very helpful model. All of these models help you to get data to show what happens in the clinical setting and what are the principles that are affecting the outcome of therapy. So we can know how can we tailor therapy for specific condition. And we can play with all the conditions based on what we want. We can change the flow rate here, so we can have different kinetics. We can have different factors, adding drug A, drug B, maybe macrophages, so we can try to simulate the human body in this case. And this is an example of outcome here when I use it for Streptococcus pneumoniae that have MEF and ERM genes. And I gave Clary for 500 milligram BID, and this was over 2 days. And we have, this is the FUE for 10 to the 6th and 5th or 4th and 2nd. And then for the control here, the bacteria grows non-stable and then stays plateaued. But when we give the clarithromycin, we could see what will happen if we give a dose of 500 milligram BID. Is going to decrease the bacterial load to almost 1/2 within 6 hours. So this tells me that when you give this dose, you can have a rapid killing of bacteria, and you can achieve full killing of the bacteria within 1 day. And it shows me what happens if you give this dose. If I change the drug, if I change the bug, I can play with all of these things to get the right dose for the patient under that type of condition. Some other people, I don't use that much, animal models. Simply, it will help us to have large amount of doses that can dissociate different kinetics here. And this is a model here that showed the time above the MIC for cefotaxime when you give it and to the rabbit murine pneumonia model. And these are the log CFU, or the colony-forming unit for the bacteria, which is Klebsiella pneumonia. And in this case, you notice that the time above the MIC and the bacteria killing, they are having some sort of lining here with the R square is almost 94%. So there is lots of association and between those things. This shows that clearly that the time above the MIC is very important factor to help killing bacteria with cefotaxime. If it was something other than cefotaxime, it will be scattered all the place, because this is not a time killer. It is concentration killer, so it will not be as organized line like this one. The last thing that I did, I showed you before, which is simply Monte Carlo simulation, where you have the PKPD model into a Monte Carlo model. And again, this is the example that I gave it to you before for the Streptococcus pneumoniae, for fluoroquinolone, and these are the conclusions. This way, we could show that when you justify the dose, when you personalize the dose to the patient in that condition, with that kinetics, with that dose, with that infection, with that bacteria, with that resistance pattern, with that gene that's causing this resistance, we could focus and try to find the best dose. And this is what we call personalized dose in this condition. We can identify the exact dose for that patient under this condition. Thank you very much. And now I have the stage to Dr. Roger Joliffe to take over and give you the real business, the real things that he's doing right now with the best dose and the p-metric things.
May I ask you a question?
Sure.
How do you measure the toxicity?
For what?
No, you see that you
For aminoglycoside, for example.
yeah.
Yeah, just try to identify the toxicity for aminoglycoside. Simply follow the renal function. Let's say creatinine clearance. Let's say BUN. All of these factors that are really factors that will show that there is nephrotoxicity from this drug.
Okay, so you don't use any of this NIC scale to measure a level of toxicity? Or?
Yeah, this is the scale here is just for general toxicity for any drug.
Yeah.
But I'm talking about more specialized toxicity for those drugs that are well identified.
Okay,
for example,
so it's more related to laboratory measurements.
Exactly. So you know that aminoglycoside causes nephrotoxicity. So you measure renal function, renal creatinine clearance.
Okay.
All of these things are important here. Okay?
Good.
Thank you.